Hi, it's Kathleen Ratcliffe. This is Nursing Management of Renal and Urologic Problems. Since we did most of this the other day, I'm going to get through this quickly, so bear with me. The key things here are not only knowing the pathophysiology and etiology, but we want to look at nursing management and collaborative care of these disorders, risk factors in particular, and you also want to look at medications, diagnostic tests, for these disorders. We want to look at those and what the nurse needs to know to properly give the medication and to assess and evaluate that it's doing what it's indicated to do and that there's no side effects. We want to look at diagnostic tests and make sure that you know what needs to be done prior to the test, what the test is like, and what else and what else needs to be done after the test, positioning and all. I just want to make sure that you do view this little video. It's about 1 minute long. It talks about NSAIDs and their effects on the kidneys. Keep in mind that they inhibit COX-2, COX-1 and COX-2, COX-1 in the um, renal afferent arterial, and so that may cause some problems with perfusion in the kidney, and the COX-2 will inhibit it and cause some fluid retention. So we did look at this question the other day, and of course you should have chosen D, that this is a normal finding. This question's from the other day, and remember, what does a nurse do first? What do all nurses do first? They assess. So this person would need vital signs, key. Uh, Looking at vital signs may tell you if they're losing fluid inside that we're not seeing. So high heart rate, low blood pressure. You want to look at respirations. You want to look at temperature, and then go ahead and do your physical assessment. This one we did not get to the other day. We did not get that far in the lecture, but I'm going to tell you right now of these, A, a 75-year-old male who is post-op and has not voided for 10 hours. This is acute retention, and this is a medical emergency, and we'll talk about that soon. So just review your notes on hydronephrosis. Same thing here, review those notes. Renal stenosis, review your notes. Blockage due to hypertension or scarring, atherosclerosis, and they're going to give blood pressure medicines to vasodilate. We did talk about stones the other day. Know that these things should be assessed when a patient has a stone. What is their diet? Has mother, father, sister, brother had a stone? What type of climate do they live in? Of course, if you're living there, you would know. Lifestyle, and especially what kind of drinks do they like. If they're liking iced tea, coffee, and not enough fluid or water, that may be one thing. And then occupational influences, things like not being able to empty the bladder. Main thing I want to emphasize here with the stones is obstruction and urinary stasis. So if a stone gets in the way and won't let the urine pass through the ureter to the bladder, that's the biggest problem. You want to look at types of stones, and that will be, first of all, you have to get one of the stones, to have the patient strain all their urine. You can either give them a urine strainer or even a cup, a paper cup of some sort, or some kind of urine container, and put gauze over top, and that will strain it. Yeah, we want to see what it's made of so we can go from there as far as treatment. Risk factors, you're going to look at how much protein is intaken, especially with the calcium and uric acid. This would be the purines and a history of gout. Struvite, UTIs, and the cysteine would be hereditary. These are greatly enlarged pictures of stones. Urinary tract calculi. So this is, we're going to see maybe blood in the urine, fever, hematuria. The person actually does what's called the kidney stone dance. They can't stay still. There's nausea, vomiting, definitely or often blood in the urine, but painful urination and just pain. They may even show a fever. You may or may not do a 24-hour urine collection, but you know the equipment. And of course, for these people, nutritional therapy, we want to make sure that they increase their level activity. If they do, make sure they increase their fluids. And they should, if they have a propensity to form stones, keep fluid levels high during really hot, dry weather. Uric acid stones, look at their diet, and same thing with calcium stones. You can't cut calcium altogether, but limit it, and they will be given lists of the food they should limit. Medications for pain or to decrease purines. We want to do diagnostic testing, KUB, maybe sometimes a ultrasound. They would need consent for an IVP, and they will get contrast. So ask all the usual questions. They would need to be MPO. And once again, make sure you know that creatinine level. It should not be performed on renal failure patients. Talk about lithotripsy. It will, blood in the urine is never normal, but they will have some blood in their urine that's normal for them. During the first few voids, they will see some blood in the urine. It should not be frank blood, and it should not increase. It should decrease. At first, it may be bright red. They will have flank pain. They will be on antibiotics. The biggest thing for these people is their urine output. So if it stops or decreases greatly, that's a problem. And this is the setup we talked about the other day. And this is where we let off. So this is trauma to the kidneys. You need to find out how this happened. Sometimes it's a motor vehicle accident. It's sometimes fights, things like that, stabbings, blunt trauma, and it could be from sports. So for this one, we have somebody who has high uric acid with their stones, and we are going to tell them C, avoid eating organ meats and sardines. This one, it's after lithotripsy, left-sided, and which one do we call the doctor about? Blood in the urine, left flank pain, left flank bruising, or a drop in urine output. Now, of course, you might want to go to the blood in the urine because I've emphasized that that is never normal. It's normal for this patient. It's still abnormal. We expect to see it, but we expect to see it decrease. Our biggest problem here is a drop in the urine output. That's an emergency. That's what you need to call it. Everything else here are expected findings. They're not normal, but they're expected post-lithotripsy. Bladder cancer. Cigarette smoking is definitely the most common risk factor. It doubles the risk. So for me, I always thought cigarette smoking and lung cancer. And then when I went to urology, I found the correlation between cigarette smoking and bladder cancer. It's more common in men, but I saw it equally probably in both men and women at that site. You also want to ask, where did they work? And have they ever had radiation for cervical cancer? Indwelling catheters for a long time, any of those. For bladder cancer, microscopic or gross painless hematuria is the most common finding. This is what the people complain about. I have blood in the urine and it doesn't hurt. You always want to investigate blood in the urine. Is it from a procedure? Is it from bacteria? But of course, the worst case scenario would be cancer. So we want to look at that too. And what are their risk factors? Whether it's surgery or chemotherapy, we want to manage them, make sure that they have the support they need, make sure they understand all procedures, and make sure all their questions are answered. Chemotherapy drugs, the one I used most was BCG. Remember that from respiratory bacilli calmette and that was what we used. What we did was we would use a straight catheter. We would straight cath the patient, drain the urine, and then we would put a 60 cc syringe into that catheter end and pour in some BCG. Most doctors like to see it drain by gravity. They didn't want to push it through. The patient after would hold that BCG in their bladder, go home, roll around, and then eventually empty their bladder and clean the toilet in a special way, usually with bleach. They had all the instructions. We had them verbalize it back to us so that we knew what they were doing. And then, of course, labs, radiologic tests. Uh, we can see bladder cancer on cystoscopy, and that's one of the best ways you can actually see it. For a cysto, there's lots of videos online. You can see if you want to see a real video. This isn't actually good. The physician or the healthcare provider is standing further away from the bladder. Actually, they're standing upright. They do not have to bend down. We're looking into the bladder. You can see it on a video monitor. You can even record the whole thing. And so the person comes in the room, they're identified, you check the orders, check allergies, vital signs, get them to undress from the waist down and prepare them, cover up. And then when the physician comes in, we do a timeout. They will numb them with numbing gel and then put the scope in. The scope is fairly long and it's got a video, a camera to it so that they can look inside the bladder. The scope has a special cleaning preparation that has to be done every single time, and it has to remain in the soaking solution X amount of time before the next patient can be seen. This question I think is pretty easy for you all right now. You would say somebody with a 2-pack per day cigarette habit, we would teach about bladder cancer. Typically in NCLEX, I know you would worry, well, what if it says lung cancer? Typically it will not. They're looking to see, do you know bladder cancer? So they would put some other things that would have nothing to do with it. Kidney cancer, and this is something that comes on. It's harder to diagnose. Cigarette smoking a lot of times is one of the problems. There's really no early signs or symptoms, and it's often not diagnosed until there's a big problem like hematuria, flank pain. So again, cigarette smoking, we look for first-degree relatives, hypertension, obesity, and again, what kind of work do you do? What were you around? What were the problems? So unfortunately, we don't find it until it's moved on. These are some of the things that you would do: nursing management and collaborative care. And you can see here, monitor for infection or hemorrhage, support the patient, a lot of coping and psychosocial. Here's your diagnostics. CAT scan is what we usually use. Okay, again, when you're looking at CAT scan or MRI, always look to see if in the question it has anything about contrast. Otherwise, don't assume it has contrast unless it says it. So other than that, for IVP does have contrast, you want to make sure you're asking all those questions. You want to make sure you explain this. Percutaneous needle aspiration, it is done on the posterior chest. It is quite painful. We numb the person up. They do need consent. A lot of times they need sedation for this one. Urinary incontinence, if you read that one handout I gave you, that's going to be your best bet. This is uncontrolled leakage of urine. You have no control. It just comes out. If you have seen television in the past 15 years, you've seen at least one commercial on urinary incontinence, and especially pads. So these are some of the things that can cause it, including confusion and dementia. Infection, we do see an increase sometimes, especially in older patients. We have more stress and urgency in women and overflow in men. So take their history, look at the type of incontinence, and that will decide the care. Pelvic floor exercises or Kegels are some of the things that we will need to do. Bladder retraining. Bladder retraining has to do with urgency, urge incontinence, and if you've ever heard of the term key in the lock incontinence. So basically what that is, I put the key in the lock of my door, and as soon as I get the door open, I have to run to the bathroom. And so what you want to tell the patient to do is try to wait for a full minute, and then keep pushing the time back every single day until your bladder's retrained. It's sort of like nerve memory, muscle memory, that it doesn't have to go as soon as you put the key in the door. The absorbent pads, the patient should be using the ones that are specific for incontinence. The nurse practitioners where I work said the others were not right for urine. It kept it too close to the body due to the differences between that and the blood, and they could always see redness when patients use that kind. There may be some embarrassment on buying pads for incontinence tied to it, so that's something that you think about. Medications, anticholinergic drugs will dry the patient up. Oxybutynin is one. So anticholinergic drugs, dry as a bone, mad as a hatter, blind as a bat, red as a beet. Those are some of the things that go with it. They are contraindicated in narrow angle glaucoma. Bladder log, they may need to keep a bladder log, and we also might do what's called a pad count, where they would take each wet set pad and put it in a plastic bag, bring them in, and then we would weigh them. And that gives the doctor good information on how much urine they're losing during a typical day. Acute retention. This is a medical emergency. It's the inability to pass urine. It can go on for a couple hours before the patient says, I can't stand it anymore. They'll be very uncomfortable. So maybe somebody will come in and say, I haven't urinated in 8 hours. That's an emergency. So the first thing I want to do, they've given me the assessment. They can't urinate. I know their blood pressure is going to be high, so taking vital signs isn't going to be valuable to me. The first thing I want to do now is plan to put a catheter in, get the order for it, and catheterize this patient, get the urine out. So you've already made the assessment, you plan, and then you implement. Then we want to find out, why did this happen? It could be from cold medication or other medications. So you want to know what type of meds they've been taking. Could be from surgery and the drying medications that might have been used. So we do see a lot of that post-operatively, where the patient maybe voids or says they void afterwards and are sent home, and then they can't void, and now they're uncomfortable. There could be chronic, not an emergency. We had some patients where the doctor said they just always have 200 in their bladder. That's just the way it is. So the risk, males, I think, are more at risk, and certainly medications. And if they have BPH, they are definitely more at risk for acute retention. Medications to relieve it, adrenergic blockers. So we want to vasodilate that area. Keep in mind that it will also vasodilate their peripheral, so make sure you're checking their blood pressure every single visit and seeing how they're doing. Tamsulosin is another well-known name, as is finasteride. Flomax works on the inside of the prostate to get things moving, so to speak. Some of the things we'll look at: urinalysis, urodynamic studies. We're going to look at the stream and how it looks, like I said the other day, ultrasound, post-void residuals or bladder scanning, and then a bladder log. Real quick, I'm going to go over urethral catheterization. This is indwelling and short-term. Suprapubic catheters, typically in quads, but I have seen this in people that were fully mobile. Neph tubes, remember that's on the posterior side, and they would have little bags to drain. And intermittent catheterization, straight cath, in this we do a lot of times spinal cord injuries. The patient does catheterize themselves. These are some different devices. You can see these in DeWitt, and I will expand a little bit on these. This is a type of orthotopic neobladder. Orthotopic means that it's where it used to be when it was the real organ. You hear urostomy a lot, but it is also ileal conduit, and it's a resection of the intestine incorporated. It's permanent. And again, orthotopic bladder, you can see here that the bladder is exactly in the same place. Indiana pouch, so it's on the inside, but the catheter part, the tubing where the urine comes out, is exterior to the body, so it would drain, the person could drain it into your urinal. pessaries, I can honestly say I never saw these till I went to urology. These are a device that is placed in to give support to the bladder, so it's actually placed into the vagina and it gives support. There's a variety of sizes. The patient is measured and fitted by the doctor, and then they're taught to take it out, clean it, and all that, and periodically checked. This is more old school now. They are still being used, but what's more being used, the evidence is showing good results with Botox. Now, it's a different concentration than the one that you would put in your forehead or around your eyes, and it works really well on working with the muscle. Here's some evidence-based practice, different things that have been shown to be really effective, like gas filters, because patients are worried since they have a bag on the exterior of their body, do they have smell? So gas filters are helpful, adhesives built into the skin barriers, things like that. So these are all evidence-based that they work and are really recommended. And that is it. So make sure that you know the different types of calculi, what risk factors are involved in all of these conditions. Risk factors are really important because that's how you screen and follow the patient so you can maybe head off the problem. Then look at types of nursing management and collaborative care. Check in on DeWitt. I think it's chapter 39 for BPH. So look at that. It's a little different instead of being in the renal portion. And then make sure you know all these risk factors. That is it, and there will be a quiz.